Welcome back to part 6 of this really annoying way of snipping up lectures. Sorry. So we were talking about pharmacokinetics. So if we talked about, let's see if I can get some drawing tools on my screen. See if I can do a multi tool. Nope. Oh, I'm new to this. Okay, I shall squiggle here. Oh, tools. Right. So if we wanted to talk about paracetamol, here's a wobbly set of axes. This one here is time. There we go, beautiful writing. And this one here is concentration. I'll just do a C. So set of axes, it's a PK graph. If we gave an oral presentation of paracetamol, we'd get a lag phase. Then it would start to absorb. It would peak, distribute, and then we'd chuck it out. So our liver would convert that and we'd bin it out. So we get an elimination curve here. Nice straight lines, eh? So that would be an oral paracetamol. If we gave paracetamol IV, so granted we do give it over a period, we don't just give it as a stat injection, but what happens is it comes in up here at a much higher concentration, and then it would sort of distribute, and then you'd find that it would eliminate. What's really interesting is that this line and this line, when it's being eliminated, they're actually parallel to each other. So the rate of elimination is the same. It doesn't matter how you give it, and the half-life is therefore the same. So it's dictated by the drug and not by the presentation. But what you will notice is that if you gave the same amount of paracetamol IV and oral, that concentration initially is much higher in the bloodstream. So you get your Cmax much quicker, much higher, and you get your Tmax much quicker. And that really suits people if they've got something like a really bad bellyache and things like that. So they want that right now, that man writhing on the floor who can't have morphine. If you're going to give them paracetamol, they need it IV, so it works much quicker. However, bear in mind, it doesn't always translate. And this link here takes you to an article where they did a randomized control trial with good placebos, and they showed that oral paracetamol was just as efficacious in real world situations as IV paracetamol. So just be aware that although that is what the pharmacology and the pharmacokinetics is telling us, it doesn't always translate out. So have a look at that one. And then just be aware, if we looked at salbutamol, so that was an indication of where you wanted a really high concentration really soon. And our patients seem to like that, and it seems to work, but just bear in mind that article. And then salbutamol, so if we did the same thing, draw a set of axes, this one's time, that one's concentration. What we really want from salbutamol is we don't want any in our bloodstream at all. So we give it by the inhalation route because that gets it straight to its receptors and straight to its target audience, target receptors, which are in the lungs. So you get a little sort of blip like this. And we really want that low concentration there. So if we don't give it by inhalation, if we injected it into the bloodstream, we get a very high concentration systemically. And that means that although it is a beta-2 agonist and works on the beta-2 receptors, it does have some carryover onto the other adrenoceptors, particularly the ones in the heart, and it gives us that nasty tachycardia. So it will work on the other adrenoceptors at a higher concentration, so just be aware of that. But what we're really after is that. So in a sort of mild to moderate asthma, this is really good. This sort of profile in the plasma concentration is great. So we can keep this low by taking the medicine correctly. So just to make you aware that if you take an inhaler, if you heat and cool that inhaler and the particles get very heavy, what happens is as you take a deep breath of that, the particles go to the back of the throat and they can't turn the corner very quickly. So they land on the oropharynx, and then you swallow those and they will go into systemic circulation and raise the systemic concentration. Also, if the particles are very, very fine, then they tend to end up in the alveoli, that's the word. So they're very fine particles, sort of get down there. And actually, what you want them to do is end up in those terminal bronchioles where the receptors are and where they're going to affect that muscle tissue that's spasming. The other thing is to sort of breathe at the right speed as well. So spacer is often indicated, and that is to slow those particles down so that they can change direction. If you inhale too fast with a traditional inhaler, often they hit the oropharynx. So it's about sort of speed and particle size that will determine whether you can achieve that. So if you get your patient and they say, oh, I get an awful lot of sort of shakes and feel my heart's racing and that, to make sure they've washed out their inhaler and kept it correctly and check it's in date, and then check their technique, because they'll probably be getting a bit of a higher concentration. So that one's sort of inhaled, you'd probably get sort of a little peak up here, but worth checking that they're taking it properly to try and avoid that. And washing out their mouth as well, that's another thing. So that's just a little bit about that. So activated charcoal is a way of changing PK. So what it does is, I had a really nice picture of a doggy here with a sort of black face where he'd obviously taken somebody's medicine and been given some activated charcoal. But this absorbs some drugs, so it's a very porous substance. It's also used for sort of bad smells, so it's put into some things to sort of take out smells because of the things adsorb to the outside of it. That's not a typo, it is adsorbs. So that will reduce the absorption of some of the drugs. So if you take something and then you take activated charcoal, a lot of the drugs will stick to it and it stops it coming out. So it will decrease its bioavailability and improve its toxicity profile. So just be aware that activated charcoal, its efficacy is based on partly on its drug's concentration. So if somebody takes an awful lot of something like an aspirin or a paracetamol, and you give them activated charcoal, it will work better because it's really hard for those drugs to get out of the stomach and out of the small intestine. So it will hang around longer. They saturate getting across the GI tract. So they work much longer as well. So generally we say give activated charcoal within an hour. But if it is quite a large overdose, then up to 2 hours it can still be effective, just because that drug's still sitting in the GI tract. So worth notifying the hospital if they're coming and they can get the nasty stuff ready. Okay, so that was pharmacokinetics, and the other branch is pharmacodynamics, and that's the effect that the drug has on the body. This is the reason that we take our drug after all, isn't it? So it's not so that we can get nice concentrations in our bloodstream, it's so that we can have the effect of the drug. And this is the bit about sort of receptors and how it works. So it includes both the nice stuff, the desired effect of that drug, and the undesirable effects. So all the horrible things that we don't want to happen. And it's part of having drugs. They are kind of toxic, but it depends how much we take generally. That dictates if they're going to be nasty to us or nice. And they draw curves in a slightly different way. So on this axis is the amount of drug. So that is like me giving you 1 milligram and then giving the next person 2 milligrams, 3 milligrams, 4 milligrams, 10 milligrams, 100 milligrams. So you give different people different amount of drugs, or one person a different amount of drug on different days. And notice that it's in a log scale. So you'll see 1, 10, 100. If it wasn't in a log scale, that piece of paper would be so long, it wouldn't fit on nicely and we wouldn't be able to see anything. So it just sort of scales it down a bit and makes it easier to look at. So it's always in a log scale. Up here on the y-axis, we have the effect. So it's actually just what you choose to measure. So if it was something like a muscle relaxant, we could get a bit of muscle and we could measure how much it reduced in its intensity and in its strength. If it was something that sort of contracted a muscle, we could measure sort of tissue contraction. If it was something like a bronchodilator, we could take peak flow measurements and measure the reduction or the increase in peak flow. So it depends what you want to measure. And we tend to find these sort of sigmoidal shaped curves. And what's happening here is you get a little bit of action straight away. And then as the receptors start to fill up, you get quite a big peak. and then you get a bit of a sloping off at the top. And that is where all the receptors are now filled up. Doesn't matter how much more you give, you're not going to get any more effect. So they tend to do this, and that's just about receptor filling. So you get a little bit of effect, and then an awful lot more of effect, just a little bit more drug, and then this sort of sloping off. So we really don't want to go beyond that if we're talking about sort of how much drug we're going to give people. If we keep giving more drug, we can measure a side effect. And again, that's dependent on what you want to measure. So you might measure vomiting rates, or sort of rates of like eye movement, like nystagmus or something like that. So it's up to you what you measure. And these tend to follow that same sort of sigmoidal curve relative to sort of how much you take and receptor occupancy. So we talk about efficacy, that's the drug working, and toxicity, and that's all the horrible things. So is it a toxic effect or is it a side effect? That's very sort of fine line, depends what you say. So things like liver enzyme changes, generally we talk about them as a toxicity because that's really nasty. But if we're talking about a cancer drug, then actually it's just one of those side effects. It's just something that we expect to happen. So all these things are relative to what you want your drug to do. So like hay fever drugs, we expect them to be really safe. We don't expect to have many nasty effects at all. But something like a cancer drug, then they tend to be a bit more horrible because you want them to do horrible things to cells. So just be aware of that. Then we need to talk about sort of PK and PD together, really. They're not sort of so separate, and the sort of how they work. So we talk about therapeutic, before that really, therapeutic index. So this is your therapeutic effect, this is your toxic effect. We talk about the effective dose 50. So if we gave 100 people our drug, at the point when 50% of them get an efficient dose that works, we call that the ED50, and that would be the amount. And then the toxic dose 50 would be the rate at the point at which 50% of our people get a toxic effect from it, and that's whatever you measure. And then there's a line between that, and that is the therapeutic index or the therapeutic window. And we can use that number to compare different drugs. Now, certain drugs have very low therapeutic indices just by their class. So things like the aminoglycosides, they're a bunch of antibiotics. Gentamicin is one of them. They just are really nasty to the kidneys and the ears, and there's not an awful lot we can do to change that. And things like warfarin and the anticoagulants. So if we don't give enough of our drug, then people tend to clot. And if we give a little bit too much of it, then they tend to bleed. And there's not an awful lot of distance in the middle. So they, by the class and by the way that they act, they have a narrow therapeutic index. Most of the drugs that we have in the ambulance service are quite wide therapeutic indexes, because the sort of way that we give them, we need them to sort of be safe. Things like morphine, that's quite narrow, and we've seen that. So if you give a little bit of your medicine and then all of a sudden you give a little bit more and your person's on the floor. So just be aware that one's got a sort of slightly narrower therapeutic index, but most of ours are quite wide. Now, what I was talking about was PK and PD. We need to consider these together. So if we have a think about aspirin, the half-life of aspirin is only about 20 minutes. It's quite a polarized molecule, and the kidneys find it quite easy to get rid of it very quickly. But the effects of aspirin last as long as a platelet lasts, which is about a month. And that is because it permanently changes the site on the white blood cell that does all the binding and coagulating the blood. So it permanently acetylates that site. So although its PK is very short, its PD is very long. So just be aware that when we're talking about them, we need to talk about them together sometimes. And this one's not as scary as it looks. Just be aware of what is on the axes. So if it's time and concentration, it's a classic pharmacokinetic curve. If it is concentration or amount of drug against effect, then it's a classic pharmacodynamic curve. But look, this one's got time at the bottom and effect. So it is a pharmacodynamic curve of sorts, but just be aware what they've measured it against. They've measured it against time. So just watch those axes when you're looking at stuff in the literature, it can catch you out. The drugs are given in different ways for different reasons. A lot of our drugs are given orally, and that's because they're convenient and very cheap as well. Cheap to make, cheap to give out, pretty stable. We don't have to keep them refrigerated and things like that. They sit around in our cabinets and our cupboards and in our drugs bags, and they're pretty good for us. If you want something to work a little bit faster, then you need to have an IV drug generally. So you inject it straight in, you get a very high concentration, and that's generally why IV is preferred. Although it comes with all the faff, doesn't it, of having to stab somebody who probably doesn't want it, and having to secure it and keep it clean and things like that. So there's pros and cons of all sorts of things. Rectal, I would like to see that gone from ambulance work. I don't think it belongs out in the out of hospital arena. Very hard to sort of keep people's dignity when you're doing it. And also very variable rate of absorption. Just be aware that on the diazepam there's a little marker, and you shouldn't insert that more than that little marker. And that's because there is a hepatic blood supply. So anything that goes into the rectum beyond a certain point, it goes up into the hepatic portal vein and up into the liver, and it has its own hepatic first pass. So it's not all going to get to the systemic circulation. So be aware of that. There is a sort of user strategy with it. Then we've got inhaled meds, so things like salbutamol will go straight to the receptors, fantastic. And then sort of buccal for things that like GTN and sublingual, where we can't get it in orally. Topical stuff that we want to apply to our skin. And then we've got all the other sort of injectables. So things like subcut are given because the absorption is a little bit slower and a little bit more prolonged. So if we've got somebody who's in a lot of pain for a long time, we don't want a big PK curve with a peak on it. We want a nice slow delivery. So just think about why we give our medicine. Is it because it goes straight to the receptor if we give it that way, or is it because we want either a slower delivery or a quicker delivery? IM, we give for anaphylaxis, we give adrenaline, and that's because if we give it IV, it's actually really nasty to the heart and causes arrhythmias. Still a lot of drug errors in that reported. And just to make you aware of some sort of clever things that are going on, this is one of these flu nasal sprays. So the kids hate needles, so they can have a nasal spray, much more pleasant. And then this one is a bit of ingenuity. So Optinose, it's called. Put your medicine in here, and what you do is you breathe in here, and then so blow into there, and then the drug gets delivered up your nose. And by virtue of that, it means none of the drug can get into the lungs because you're breathing out at the time. So there's so many clever ways around this. If we're looking at introducing new medicines into the ambulance service, then it's probably going to be a new route of delivery that you'd be looking at, and that would be a sort of something that you could do. I don't think we're clever enough with this at the moment. I think we can do better, but there's got to be a sort of cost behind it, and it's got to be justified. So does it benefit our patients or us? Things like needles, we're trying to get away from those if we can. So if there's a better way to give it, then we'll look at that. But a lot of the sort of new drugs that we get in ambulance service and new medicines are because they're sort of given in a different way. So that's something for you to think about. And for your project in your third year, you might think about sort of a drug delivery route that's new. That'd be something for your sort of EBP project. Have a chat with me if you want. So loads of other ways of giving drugs. There's one I was going to talk about, yes. So sort of nasal goes straight up to the blood-brain barrier, often quite a nice way of getting things into there. And just be aware that a lot of patients are on sort of feeding tubes and things like that. So I've seen GPs who've written prescriptions for tablets and they can't go down tubes. It needs to be a solution or a suspension. So yeah, we have to be careful with that. And then kids need a sort of something that's a bit more kid friendly, don't they? So use reformulating. Right, end of that one.